Hello everyone. Welcome to today's session on heart failure. Let's begin with a clinical scenario. A 58-year-old man comes to the outpatient department complaining of progressive breathlessness for the past 2 months. Initially, he became breathless only while climbing stairs, but now even walking a short distance makes him feel exhausted. He also tells you that he cannot lie flat while sleeping and needs 2 or 3 pillows to breathe comfortably. Sometimes, he suddenly wakes up in the middle of the night with severe breathlessness. In addition, he complains of fatigue, reduced exercise capacity, and swelling of both feet over the last 2 weeks. On examination, you find basal lung crackles, raised jugular venous pressure, bilateral pitting pedal edema, tachycardia, and an S3 gallop. Now, before we jump to the treatment, I want you to think like a clinician. Ask yourself 4 important questions. First, what is the most likely diagnosis? Second, what are the major problems in this patient? Third, what should be our therapeutic targets? And finally, which drugs can help this patient, and why? If we can answer these 4 questions logically, then heart failure pharmacology becomes very easy. So, let's start with the first question. What is the most likely diagnosis in this patient? Now let's answer our first question. What is the most likely diagnosis in this patient? The answer is congestive heart failure, most likely acute decompensated heart failure or chronic heart failure. But don't memorize the diagnosis. Instead, let's understand why. Look at the patient's symptoms. He has progressive breathlessness on exertion, which tells us that the heart is unable to pump enough blood to meet the body's demand. He also has orthopnea, he cannot lie flat, and paroxysmal nocturnal dyspnea, where he suddenly wakes up at night gasping for breath. These are classic signs of pulmonary congestion, meaning fluid is accumulating in the lungs. Now look at the examination findings. Basal crepitations again suggest pulmonary edema. Raised JVP, bilateral pedal edema, and hepatomegaly indicate systemic venous congestion, meaning blood is backing up into the systemic circulation. The S3 gallop suggests volume overload and a dilated ventricle, while tachycardia is the body's attempt to compensate for reduced cardiac output. So, this patient has evidence of both forward failure, where the heart cannot pump enough blood, and backward failure, where blood backs up into the lungs and systemic veins. That is why the diagnosis is congestive heart failure. But remember, diagnosing heart failure is only the first step. The next and more important question is, what are the major problems in this patient? Once we identify those problems, choosing the correct treatment becomes simple and logical. So, let's move to the next slide. Now that we know the diagnosis is heart failure, the next question is, what are the problems in this patient? Remember one important point. Heart failure is not a single problem, it is a syndrome with multiple interrelated problems. In this patient, there are 3 major problems. Problem number 1, weak pump. The heart has become weak and cannot pump enough blood to meet the body's metabolic demands. As a result, cardiac output decreases. Organs receive less oxygen and nutrients. The patient develops fatigue, weakness, and reduced exercise tolerance. This is called forward failure because less blood is moving forward to the organs. Problem number 2, congestion. Since the heart cannot pump blood efficiently, blood begins to accumulate inside the ventricles. This increases the end diastolic pressure, and the pressure is transmitted backward. If the left ventricle fails, blood backs up into the lungs, causing pulmonary congestion, which explains the patient's breathlessness, orthopnea, and paroxysmal nocturnal dyspnea. If the right ventricle fails, blood backs up into the systemic veins, producing raised JVP, pedal edema, hepatomegaly, and ascites. This is called backward failure. Problem number 3, harmful compensatory mechanisms activation. Now the body tries to help. It activates the sympathetic nervous system and the renin-angiotensin-aldosterone system, or RAS. Initially, these mechanisms maintain blood pressure and organ perfusion. But over time, they become harmful. They cause vasoconstriction, sodium in water retention, and cardiac remodeling, making heart failure progressively worse. So, always remember these 3 major problems. Weak pump means decreased cardiac output. Congestion means increased end diastolic pressure. Harmful compensatory mechanisms activation means activation of SNS and RAS. Once we identify these three problems, the next question becomes very easy. What should be our therapeutic targets? Let's answer that in the next slide. Now we know the three major problems in heart failure. But knowing the problems alone is not enough. As doctors, our next question should be, what should be our therapeutic targets? Remember one simple principle in medicine. Every problem should have a therapeutic target. Let's identify them one by one. Therapeutic target number 1. The first problem is a weak pump, which leads to decreased cardiac output. Therefore, our first target is to improve cardiac output. We can achieve this by improving myocardial performance and reducing the workload of the heart, so that it can pump blood more efficiently. Therapeutic target number 2. The second problem is congestion, caused by an increase in end diastolic pressure. So our second target is to reduce congestion by decreasing end diastolic pressure, reducing preload, and removing excess salt and water from the body. As congestion decreases, the patient's breathlessness, orthopnea, and pedal edema also improve. Therapeutic target number 3. The third problem is the activation of harmful compensatory mechanisms, mainly the sympathetic nervous system and the renin-angiotensin-aldosterone system, or RAS. Initially, these mechanisms are protective, but in the long term they damage the heart. Therefore, our third therapeutic target is to block these harmful neurohormonal mechanisms, prevent cardiac remodeling, slow disease progression, and improve survival. So, remember these three therapeutic targets. Improve cardiac output. Reduce congestion by decreasing end diastolic pressure. Block harmful compensatory mechanisms. Once we know these targets, choosing the drugs becomes very logical. Every drug used in heart failure is designed to achieve one or more of these therapeutic targets. So, let's move to the next slide and answer our final question. Which drugs can help this patient, and why? Now we have reached the most important question. Which drugs can help this patient, and why? Many students try to memorize the names of heart failure drugs. But today, we are not going to memorize them. Instead, we are going to understand why each drug is used. Remember, every drug is prescribed to solve a specific problem. Let's see how. First problem, weak pump. The patient's heart has become weak. It cannot pump enough blood, so cardiac output decreases. Therefore, our first goal is to improve forward blood flow. Which drugs can help? In selected patients, positive inotropic drugs such as digoxin, dobutamine, and milrinone increase the force of cardiac contraction and improve cardiac output. But there is another way. Instead of making the heart work harder, we can make its job easier. Drugs such as ACE inhibitors, ARBs, ARNI, and hydralazine reduce afterload, allowing the heart to pump blood more easily. Second problem, congestion. The second problem is fluid overload. Because blood is not pumped efficiently, end diastolic pressure increases, leading to pulmonary and systemic congestion. Our goal is to remove excess fluid and reduce filling pressure. For this, we use diuretics, especially furosemide, which removes excess sodium in water. We also use nitrates, which reduce preload by increasing venous capacitance. In addition, mineralocorticoid receptor antagonists, such as spironolactone and eplerenone, and SGLT2 inhibitors, such as dapagliflozin and empagliflozin, also help reduce congestion. As congestion decreases, symptoms like breathlessness, orthopnea, and pedal edema improve significantly. Third problem, harmful compensatory mechanisms. The third problem is the activation of the sympathetic nervous system and the RAS. Initially, these mechanisms try to maintain blood pressure. But over time, they worsen heart failure by causing vasoconstriction, fluid retention, and cardiac remodeling. Therefore, we must block them. For this, we use beta blockers to inhibit the sympathetic nervous system, ACE inhibitors, ARBs, or ARNI to block the RAS, mineralocorticoid receptor antagonists to block aldosterone, SGLT2 inhibitors, which further reduce disease progression and improve outcomes. These drugs are not just symptom-relieving drugs. They are life-saving drugs because they slow disease progression, reduce hospitalizations, and improve survival. Take-home message. So remember this simple concept. Weak pump needs improve cardiac output. Congestion needs reduce end diastolic pressure. Harmful compensatory mechanisms activation needs block SNS and RAS. And every drug used in heart failure works by targeting one or more of these three problems. That is the real logic behind heart failure pharmacology. Thank you.